So the stuff that we're going to cover in transesophageal echo, we're going to look at the indications, okay, the contraindications, how you prepare the patients, the equipment you need, the views, the standard views in pathology. And all of these different topics are very, very important, um, you know, because you're doing the study, you have to know why you're doing the study. You know, why am I doing this study? Did the patient have a stroke? Is the patient going for some cardiac surgical procedure? Did Are you looking for aortic dissection? You know, so you have to have a good indication for doing the study. Patient have endocarditis, so you're looking for vegetation. Uh, and then equally important is when you shouldn't do the study. You know, what are the contraindications? We have absolute contraindication and then relative contraindication. So when you should and when you should not do the procedure. And then how you prepare the patient, which is very important because if the patient is not prepared properly and you don't have the right equipment, you can run into problems. Okay. Um, the the equipment again that you need, you can't do the procedure unless you can monitor the patient in terms of cardiac monitor, rhythm, blood pressure, pulse oximetry, because the patient can get into problems. And if you don't have a pulse ox setup, you would know, you know. Uh, and then the views and the pathology that we look for. All right. So when we say transesophageal echo, what we mean is we use it's a probe, and because we put the probe in the patient's esophagus, so we said we intubate the esophagus. So the probe is positioned in the esophagus, so it has to be an endoscope. So it has to be a long tube-like structure that you can insert in the esophagus. And we usually use the frequency probe up to about 7 megahertz. Okay, so the frequency is usually up to about 7 megahertz. And we put the probe in the patient's esophagus, and the esophagus lies just behind the heart. So we can see the structures in the heart, especially the posterior heart structures. Okay, so this technique allow you to have superior visualization of the posterior cardiac structures and the valve. So it's if you know it's very good for looking at the mitral valve. Um, Very good for looking at the left atrial appendage. As a matter of fact, you can't see the left atrial appendage by doing your transthoracic echo. So you have to do a transesophageal echo to see the left atrial appendage. So usually the patient is lying uh, supine on their back, or you can do left lateral position. I don't care what position it is. I was trained patient lying on their back, supine. But a lot of institution, the patient is lying on their left side. Uh, uh, doesn't matter. Essentially, the esophagus. Well, this is the oral cavity, the pharynx, and then you get into the esophagus. This is the esophagus right here, okay, and then the heart is just above. Okay, the patient is lying down, so the heart is superior to the esophagus, and this is your probe. So the probe, you insert the probe in the esophagus, and at the tip of the probe there's a camera, and the camera allows you to look at the heart. So you can get essentially unobstructed visualization of the heart. So very good technique Some institutions, you do 3, 4 a day. Um, you know, and again, if it's a large institution and you do any cardiac surgery, then again, almost you know all the procedures they're going to require transesophageal echo to be done. All right. So if you visualize the patient sitting up, or the esophagus is at the back. So this is the esophagus leading into the stomach, and then the heart is just in front of your esophagus. So this is your probe right here. The camera is on the tip, and you have connectors on the transesophageal probe, which allows you to rotate your camera. So you can rotate the camera from 0 to 180 degrees. And not only you can rotate the camera, which is on the tip, but you can rotate the probe itself. And then there are other connectors where you can flex the probe. When we say flex the probe, you can bend the probe upwards. So you can anti-flex it, bend it upwards, or you can dorsiflex it by bending it backwards. Okay? You can also move the probe from side to side. So these maneuvers are very important depending on what structure you want to visualize. Okay? So you have a lot of, you can do a lot of manipulation with the probe. All right. So what are some of the indications for doing your transesophageal echo? Why should you do it? So if you're looking for if the patient had a stroke, or if the patient have, say, a blood clot in the leg, and you think that blood clot in the leg is coming from the heart, then you have to look at the heart, and you have to look at the inside of the heart to see if there's any blood clots, especially if the patients have atrial fibrillation. Patients with atrial fibrillation, clots usually live in the left atrial appendage. So you should, look for clots there. And then again, sometimes you may see clots or tumors that you didn't expect to see. So, if there's an embolic phenomenon, what we mean by that, if a clot is in an area that it shouldn't be, well, the clot shouldn't be in any area. But if you think the clot is coming from the heart, then you can do your transesophageal echo and look at the heart. So common places where you'll find clots, patient have a stroke, embolic stroke. So, I had a patient today who had a stroke, and she had multiple clots, not just one side, multiple sites in the brain. So of course it's reasonable to look at the heart to see if the source of the emboli is in the heart. So that's one. Then we talk about endocarditis. So when we talk about endocarditis, we talk about infective material, usually on one of the heart valves or more than one of the heart valves. So these are infective material that usually resides on the heart valve, and then the patient will come with evidence of infection. Sometimes they look sick, they'll give you chills, night sweats, white cell count will be elevated, they may have a temperature. When you listen to the heart, you might hear a loud murmur telling you that the one of the valve is not functioning well. And then, of course, you have to do blood cultures and all that sort of stuff. But your echo is one of the mainstay in making the diagnosis of endocarditis. And, we have a separate lecture that we look at endocarditis and how you make the diagnosis and we'll talk about the modified Duke um, criteria. But anyway, you're looking for infected material. We call that vegetation, and it's usually self-evident. If you see it, you'll recognize it. Um, we talk a little bit about left atrial appendage thrombi in patients with atrial fibrillation, also in patients with mitral stenosis. Uh, you can have left atrial appendage thrombi. Prosthetic heart valve dysfunction. So if the patient had usually a mechanical prosthesis or sometimes a bioprosthetic valve, and you have indication that the valve is not functioning well, or the patient may present with shortness of breath and stuff like that, and you want to look better at the valve, then transesophageal echo is a very good tool to utilize. Aortic dissection, that is a tear in the aorta. If you can do a transesophageal echo quickly, then you can, especially patient is in the emergency room and you suspect aortic dissection. Instead of swinging the patient to the CAT scan, and that might take a little time to get the CATs, the CT scan staff up and running. You can quickly do a transesophageal echo. You can make your diagnosis. Um, so we can use it for the diagnosis of aortic dissection or just plain aneurysm. Again, cardiac surgical procedures, more and more heart procedures uh, done under the guidance of transesophageal echo. So, in the larger institution, you have a dedicated team that they just work in the cardiac suite, and they'll be doing transesophageal echo all day, uh, because you'll have a lot of cardiac procedures. Mitral regurgitation, anything I would say anything more than probably mild mitral regurgitation, you should at some point in time do a transesophageal echo, because you want to fully characterize the mitral regurgitation. That is, you want to determine the severity of it. You want to determine the mechanism, what's the cause of the mitral regurgitation, and then you can plan the treatment for that patient based on your transthoracic and your transesophageal echo. So mitral regurgitation, definitely. Patients with aortic pathology, aortic valvular pathology, not so much. The transthoracic echo usually is sufficient. You're not going to have much by doing a transesophageal echo. In rare cases, you're looking for dissection going down to the valve and stuff like that, or vegetation of the aortic valve. Um, Another important indication is if your transthoracic echo is suboptimal. That is, you can't see the endocardial border fairly well, you can't see the valvular structures well, then that's an indication to do a transesophageal echo. And then if there's any intracardiac masses, then your transesophageal echo is the way to go. What are the contraindications now? So I think there's some revision in this where they're just, in terms of, instead of talking about absolute and relative contraindication, they just talk about the contraindications. But the old classification of the absolute contraindication, that is, under no circumstances you should be doing transesophageal echo if the patient is known to have esophageal spasm, esophageal stricture, as is where the esophagus, usually probably from scarring or whatever means, is very narrowed. And those patients will have, dysphagia, difficulty in swallowing, and they'll tell you that. esophageal laceration for whatever. You don't want to do a transesophageal echo. Esophageal perforation, if they have a tumor or whatever, you suspect esophageal perforation, you definitely don't want to do it. And then esophageal diverticular, it's basically an outpouching. It's an outpouching in the esophagus, like a little sac. You don't want to do a transesophageal echo in those patients because the probe can go into that outpouching and rupture it. So you don't want to do it. Um, you know, and of course, this is the old classification where we talk about relative. A large diaphragmatic hernia, cervical disease, that's problem in the neck, upper gastrointestinal bleeding, difficulty in swallowing, pain in swallowing. You're always going to weigh the benefit against the risk of doing these procedures. So, if you're not going to glean a lot of information, if you find, or it's not going to change your management a lot, if you do the TE, then you probably shouldn't do it. But if you highly suspect endocarditis and or dissection, and the patient might have a little bleeding, the benefit in doing the procedure, would far outweigh the risk. So you go ahead and do it. How do you prepare the patient? And this is probably the most important thing you're going to do, because if the patient is prepped well, then you might not have much problem doing the procedure. That is, the patient shouldn't have anything to eat for at least 8 hours, because if the patient eats anything, the chance of vomiting and aspiration is going to be great. So nothing to eat for at least 8 hours, okay? You need to explain to the patient what you're going to do in detail and the risk involved, so that they're fully understanding what you're going to do. So if something happened, they say, oh well, the doctor did say that's a possibility. If the patient have any dentures in, you have to remove the dentures, because you can knock those things down and patient can swallow them, or aspirate it into the bronchial tree. So remove the dentures. Make sure you have intravenous line, especially in the antecubital area. If you're gonna do saline contrast studies, you need a large bore IV line in the antecubital area. So don't send the patient to the procedure room with a line in the hand and expect to do a contrast study. That wastes time. So, if you're going to do a transesophageal echo and the patient have a CVA, have a stroke, then a saline contrast study is one of the things you're going to do. So make sure that there's a large IV line in the antecubital area, so that when the patient gets to the procedure room, you don't have to be trying to put up a line to do this procedure. All right. Again, you have to have functioning monitors, ECG monitor, blood pressure monitor, pulse oximetry, because sometimes the patient might be getting into trouble. It might be hypoventilating, and the O2 saturation might be 60%. If you don't have a pulse oximetry on, you won't know that. Okay, you might think the patient is just sleeping and very cooperative. So make sure you have your necessary monitors. ECG monitored, blood pressure monitored, pulse oximetry. Make sure you have a suction apparatus because secretion can build up and the patient can aspirate if you're not suctioning the oral cavity. So make sure you have a functioning suction apparatus. Beforehand, you need to know what sedative you're going to use and make sure you have sufficient quantity and make sure you have reversal agents. Okay? Because sometimes you might give, say, if you give Versed, even 2 milligrams of Versed might severely sedate the patient. The patient may be very sedated and start hypoventilating, not breathing adequately, and you might have to reverse the patient. So make sure you have reversal agents. I don't do these procedures unless I have reversal agents, because if I need to reverse the patient quickly, then I need to do it. So you have your sedative, know what you're going to use, make sure you have reversal agent, and then your anesthetic spray. So we usually spray the back of the pharynx, the back of the throat, with either lidocaine or lidocaine spray. So complications. So even the best of us do get complications from time to time. If you do enough of these things, you will get some complication, and you might do everything right, but patients differ, and patient may have an anatomy that lends itself to some type of complication, but the complication rate is less than 1%. So, it's an invasive procedure, so you will get some amount of complications, and the potential complications, laryngospasm. So the case I did today, patient did have laryngospasm. For whatever reason, sometimes when you put the probe in the back of the throat, the larynx can go into spasm and can close down. So so she desat a little bit. Her O2 saturation went as low as in the 60s. We just repositioned. We had finished the procedure. We just reposition her neck, give her oxygen, and she just come around. Okay, so you have to recognize the complications and then treat it. Laryngospasm, it's real. So if you didn't have pulse oximetry on board, you would know. Patient can, after the procedure, the patient can complain of pain in the throat because you're putting this probe in the back of the throat into the esophagus, so they can have pain in the throat. Shortness of breath, okay? So they can develop shortness of breath if they aspirate, or even from the laryngospasm. So the examiners love to bring this methemoglobinemia, so you need to know everything about it. It's very uncommon. We don't see it, but it's a good exam question. They love to bring it. So you tend to get it with the benzocaine type of local anesthesia that we spray the back of the throat with, and if you use too much, it can convert the Fe2 plus in the hemoglobin to Fe3 plus. So remember, hemoglobin contains iron, but the iron is Fe2 plus. When you give, say, something like benzocaine, you oxidize the Fe2 plus and you get Fe3 plus. The problem with Fe3 plus is that when it binds that type of hemoglobin, when it binds the oxygen, it does not release, it doesn't give up the oxygen. So even though there is oxygen, the hemoglobin is not serving the purpose of giving oxygen up to the tissues. So it binds the oxygen and don't give it up. So the patient is deprived of oxygen, essentially. So when you check the blood, the methemoglobin level, which is hemoglobin with Fe3 plus as opposed to Fe2 plus, is elevated. And we use methylene blue, so that's another exam thing. You use methylene blue to treat these patients. So, all right, and of course we mentioned the patient can aspirate. All right, other complications that you can get: hypotension, because you're using medications, and all that sort of stuff. The patient blood pressure may fall, or they may go the other way. They may develop hypertension, elevated blood pressure. Okay, um, and then some patients will have tachycardia, rapid heartbeat. So because it's an invasive procedure, um, so you know so patient may develop tachycardia. You can get esophageal rupture. So if there's pathology in the esophagus, so the patient have esophageal cancer and you didn't know, and there's weakness in the wall of the esophagus, you can perforate. You can perforate that. Okay, or there's any other pathology, you can cause perforation. And death is a rare complication. We don't see patients don't usually die from transesophageal. They do, but not regularly. Okay. Again, medications. I like to use midazolam or Versed and fentanyl. Okay. So some other operators will use Demerol. Mainly for this is mainly pain, right? But midazolam or Versed, um, fentanyl, Demerol, those are some of the medications you use. So what I'm going to do is stop here, and then our next session will go into pathology, and we'll look at common pathology, and then we will um, look at the mitral valve, because the mitral valve is a big area in transesophageal echo. Um, you know, especially in patients with mitral valve prolapse. Um, Patients with mitral valve prolapse, um, we we usually evaluate these patients, uh, and then if they're going to have procedure, the mitral clip or mitral valve repair for whatever reason, the surgeon like to know which scallop is involved, or which scallop. So we'll look a little bit into the different scallops. Um, Another thing that is gaining prominence is the Watchman procedure. The Watchman procedure is an occlusive device that would put in the left atrial appendage to occlude the left atrial appendage. And this is usually in patients who have atrial fibrillation and have a great chance of forming clots in the left atrial appendage and then embolization. Patients who have some contraindications to anticoagulants. That is, you can't give them blood thinners because they may have significant gastrointestinal bleed, or they may have had a central nervous system bleed, a bleed in the brain. So you don't want to give them blood thinners, but you want to reduce their risk of blood clot formation in the left atrial appendage and embolization. So that's becoming very popular now. So we would do a transesophageal echo to look at the left atrial appendage, size the left atrial appendage so that we can put in this device. So we're gonna spend a little time looking at those different uh, features.